Good afternoon, everyone. Um, Glad to be here again. And it's really heartening to see all of you signing in this afternoon, Friday afternoon. In Chennai here, it is a pretty hot Friday afternoon. And I took up this topic of triaging for two reasons. One, I have actually led an emergency department for about 10 years, and I know the importance of triaging. And also, the triaging is done by nurses. So the triage nurse is the one who actually is the gatekeeper to the emergency department. And most often, if you see, it'll be the junior most nurse who will be there. So it is very important that actually a person who's more experienced and who knows a little bit about triaging to be the triage nurse. So for this reason, I thought, let me go through the various points which I wanted to share, that I feel anybody who is doing triaging or anybody who's involved in triaging must know these facts. And there's a lot more to learn. Now, it's only, I'm just giving you a brief overview and how to go about triaging. So this is my purpose. So with that introduction, let me start. So triaging is what we are going to talk today. So there's no poll today. As the agenda is this. Now I'll talk about 5 main topics. First, an introduction about triage and why we do it, where all is triaging used in healthcare, and the various triage system that exist all over the world. Then more specific in how a person who's doing triage should go about doing the triage. It's just not using the tools, but a lot more to it. So I will explain that and how to perform triage. And finally, we'll talk about special considerations, the various populations where we need to be more careful while doing triage. So that is the special considerations in triage. So let's start with what is triage. So triage is the process of prioritizing the patient treatment based on the severity of the condition. So if you go to an outpatient department, you will be scheduled according to the time of arrival or according to your appointment time. But when a patient comes to any emergency situation, then the person who's got the more severe illness is the one who will be seen first. So that is the whole purpose of triage. It is the prioritization of the treatment based on the severity of the condition. And where it is used, it's mostly in hospital departments, disaster scenes, mass casualty incidents is where triaging is used. So it is used in the field and in hospitals as well. So what is the purpose of triage? Very broad philosophical thing is like the Harry Potter series, the greatest good for the greatest number of people. It's not actually true. Many times in disasters, we may actually restrict the number of the treatment to the people who actually survive. But in civilian emergency departments, in departments where there is much more order, then this philosophy is actually very apt. We want to do the greatest good for the most sickest people. Thereby, we are also helping the others in the population. So that is the urgency factor in triage. So there are, from the healthcare organization, the purpose is twofold. One, it is to facilitate efficient use of medical resources and personnel. Suppose you have just 4 beds in your emergency department. You need to make sure that 4 beds are utilized to the maximum for the needy patients, and also your personnel are optimally used. Similarly, the other resources in the hospital, like ICU beds, medical specialists, are allocated to the patients who need them most. So this is the purpose which triage does, and the whole emergency department revolves around this. So triage is started during the battle. It is from the French word trial. During the Napoleonic Wars, it is what this concept was started. The concept was totally different. It was to triage the soldiers who were fit enough so that they were treated immediately and sent back to the battle. So that is what this purpose of triage was for in the battlefield. And slowly it evolved, and we are using it in the other areas as well. So if you look at where is triage used in healthcare, so the first, as I said, is it in hospital, and where all in hospital it is used? It is used in all these areas. So we are not only talking about emergency departments, even intensive care units triage patients, because anywhere there is a certain limited number of resources, you will necessarily need to have to triage to make sure only the most urgent and most severe patients are admitted to those beds. So intensive care bed is another one. Outpatient departments also, I will explain, will use triage, and in fact NABH wants us to use triage in the outpatient departments, and also in specialty clinics like chemotherapy in other areas also triage is utilized. So there are both in hospital and ambulatory areas it is being used. In the field, as I told you, mostly in the disaster sites, mass gathering events like the Kumbh Mela and all that, if something happens, then you need to be ready with the triage system there. And pandemics, we saw that. As I said, whenever there is rationing of beds, then triage will come. So there, the demand outstripped the supply in COVID because of so many people getting sick at the same time. And therefore, we had to use triage even during the pandemics. And the ambulances personnel, the paramedics, regularly use triage, and they use it to decide the appropriate level of care and to where they have to take the patient. So if it is a private ambulance, it will take them to that particular hospital. But all public ambulances work in this principle of triaging the patient to the appropriate level of care, whether they want to do a secondary level or tertiary level, and to the hospital which is the most equipped, not necessarily the nearest. Okay, so that is also the way in which the ambulance personnel triage patients when they pick up the patients from the field. So that is the in-field triage. Now, triage levels in general will be 4 or 5. So I'm going to generalize here. Then we'll go into the specific systems. So the triage levels, the level 1 is the red. Sometimes the color is used. It's for life-threatening emergencies requiring immediate attention and attention without delay. Here we have to start the treatment within seconds or minutes. So that's level 1. Level 2 may be either orange or yellow. Serious but not life-threatening. But if you don't treat them, they will deteriorate. So this treatment will start anywhere between 30 minutes to 2 hours, depending upon the emergency and the emergency department and where you live. Semi-urgent, sometimes green, sometimes blue. Stable patients with non-life-threatening conditions who need medical attention within few hours. These are probably patients who will need some investigations. And 4 is non-urgent. They require medical attention but can wait without any deterioration for even a few hours. And finally, white is minor patients who can be managed as an outpatient. Okay, so these are the 5 triage levels. As I said, is very general. And some examples: red is major trauma, cardiorespiratory arrest, or major GI bleed. Yellow is myocardial infarction, acute asthma. Level 3, green is single bone fracture or acute abdomen pain, which requires investigation. Level 4 is non-urgent, minor cuts and abrasions, aches and pains, backache, shoulder pain, things like that. And finally, any patient who just comes probably with a symptom which he could have gone to an outpatient department, they are classified as minor or white color. So that's the, as it's like generic, in medicines, there are generic names and brand names. So in triage, these are the generic levels. And now we will get into the brand names. Okay. So the brand names are otherwise known as triage systems. So there are several triage systems available all over the world. The Manchester triage system, the emergency severity index, the Australasian triage scale. So what is Manchester triage systems? Basically in Europe and UK, 5-color scale, and it categorizes based on urgency and response. We will talk a little bit in detail about this. The next is the emergency severity index, which is mostly used in United States. Again, 5 level. It takes into consideration the severity as well as what are the resources which are required to treat a patient. And Australasian is similar to MTS, that is Manchester triage scale, but the time is slightly different. And next we have the Canadian triage and acuity scale, similar to emergency severity index and tailored to the Canadian healthcare system. Canadians borrow from US, but they give it always a twist because they live so near to the United States. Start is the pre-hospital triage, simple triage and rapid treatment, usually for mass casualties. And it just, it classifies them into immediate delayed, minor, or deceased. So immediate transport, delayed transport, minor injuries which can wait for the transport to be transported, and then people who are not alive. And finally, modified early warning score can also be used to triage, grouping them into 4 or 5 groups. So let's talk about the Manchester triage scale. So Manchester triage scale is a very extensive triage system. So it starts with, they have actually, their philosophy is you cannot apply a triage, for everything. You need to have specific triages for different domains. So they have 5 domains. There is a triage system which is used in emergency department. There is one for telephone triage, one to be used by paramedics in the ambulances, one in the nursing homes and old age residential homes, and finally one which can be used by GPs on a community basis. Okay, so these are the 5 domains in which they have classified the triage system. And each of these will have flowcharts. So total, there are about 52 flowcharts for various chief complaints. So they not only talk just in general about, red, blue and all that. For each and every chief complaint, for 52 chief complaints, for example, for headache, there is a certain way you have to triage. The various gradations will be there for headache. The various gradations will be there for shortness of breath, like that for 52 various chief complaints. Then for each of these, that is the flow charts, there are what are known as discriminators. For example, if it is shortness of breath, then there will be a discriminator which says, does the patient have airway compromise or not? And if it is abdominal pain, is it mild pain or severe pain? So likewise, these discriminators will classify them into these urgency categories. Okay, the urgency categories are 5: red, which you need to treat immediately; orange, which is very urgent within 10 minutes; yellow is urgent within 60 minutes; green is standard within 120 minutes; and blue non-urgent within 240 minutes. So this is how the Manchester triage scale works. It is now outside the scope of this 30 or 40-minute talk to talk more in detail about it. You can, of course, go to there is a separate website on Manchester triage scale. You can access it and learn more about it. So emergency severity index, as I said, now these are the 2 main things. Europe, Manchester triage scale, and in the US, it is the emergency severity index. The emergency severity index, as I said, is based both on the severity of illness and on resources. That is the specialty of this. How much of resources is required to treat a patient is the basis for triaging, and it uses 4 decision points. So A is the first decision point. Does this patient require life-saving intervention? If the answer is yes, it is level 1. If no, that does not require life-saving intervention, the next decision point is the patient high risk, confused, or distressed? Again, they will give you a detailed list of what are all the high risk conditions. So based on that, you can decide. Or is the patient confused, or is the patient in any distress, either because of pain or bleeding or whatever it is, or even emotional distress? So if this is yes, they will be triaged as 2. So if they are not high risk, confused, or distressed, then you got to go to the third decision point. And that decision point is not about the severity of the illness. It asks how many resources are required to treat this patient. Okay. So before you ask this question, you got to ask them also, is there any high risk vital signs? So what do you mean by high risk vital signs? Say heart rate of more than 120 or less than 60, respiratory rate more than 30 or less than. So you remember, either it is very high or very low, which patient may collapse at any point of time. So based on these vitals, these are the high risk vitals. If they fall into the high risk vitals, they are retriaged into 2 and then treated likewise. But if there is no high risk vitals, then we have to decide how many resources are required. If many resources are required, they are classified into 3. If only 1 resource is required, they are classified as 4. If no resources are required, then they classified as 5. So you may be asking, what is this resources? So this is how emergency severity index classifies resources and non-resources. So if the patient requires labs, ECG, X-ray, computer tomography, any of the imaging, or you have to start an IV, or you have to give IV, IM medications, or if the patient requires specialty consultation, or a simple procedure like laceration repair, or a complex procedure, then it is a resource. So if it is many of these resources, it will become 3. If there's only one resource, suppose you just have to ask for a specialist consultation, then it is counted as 1 resource. Okay. Whereas they do complex procedures, it will be considered as 2 resources because a lot of people need to be involved in that. Okay. So based on this, you will decide whether it is 3, 4, or 5. So these are not resources on the right side. Okay. So this said, no, non-resources, not ESA resources. If just taking history, point of care testing, flushing a line, oral medication, giving TT, giving prescription refills, phone care, calling an outside doctor, simple dressing change, giving them crutches, splints and all that is not counted as a resource. So they're very clear. Okay, so based on that, you divide it into these categories. We did implement ESI in our emergency for nearly, I think, 2 or 3 years, but we found that the nurses find it very difficult to do this. It requires a little bit of experience in this, so we actually give up. So you could try it, so it may work in your hospital. So next, a little bit about Australasian triage scale. It's again 5 levels: immediate, very urgent, urgent, standard, non-urgent, almost like MTS. And this also has got clinical descriptors to classify the urgency. Here, the times are slightly shorter. So if you compare the Manchester system, the orange is 10 minutes instead of 30 minutes, green is 30, blue is 60, white is 120. So if you remember, Manchester triage, the outside limit was 240. Here within 120 is the maximum limit. So it's slightly varying from the Manchester triage scale. So this is how the Australian triage scale works. So this is the category. You have to, there's orange. Within 10 minutes, you have to do treatment and simultaneous resuscitation. So this is classified based on this: immediately life-threatening, time-critical treatment, and they give some measurements or vital parameters by which or symptoms and signs by which you can classify them into category 1, 2, 3, 4, and 5. So that's the Australasian triage scale. Now, Muse modified early warning score also can be used to triage. Now, if you know about Muse, at the end of the Muse assessment using this Muse chart, okay, it uses these vital parameters: respiration, saturation, whether they are on supplemental oxygen, blood pressure, pulse, consciousness, temperature. These are vitals, right? So based on these vitals, you have a scoring system. And if the score is 0, they are supposed to be of no risk, 1 to 4 low risk, 5 to 6 moderate risk, 7 or more high risk. So based on that, they are triaged. So high risk is 1, moderate risk is 2, low risk is 3, and no risk is 4. So some Muse systems will classify the high risk itself into high risk and very high risk and high risk, and so it will be 5 triage levels. That's all individual, because the scores could be 7 and more, can be up to 15 or even 18. So you can actually have 2 gradations there. So that's the Muse triage scale. Now we have talked about the overall triage levels and what are all the triage systems, very common or very important triage systems that are available in our world. And now we will get into the specifics. I told you, as a triage nurse or one who triages the patient, how should you perform the triage? So this is very specific, and this is a skill that we need to take away from today's webinar. Okay. So triage, actually using those tools, starts from step 4 only. So before, there are 3 other steps you have to do before you perform triage. Very, very important to note this. So first look, immediately look at the patient. It is also known as a critical look. You ask many times with experience, just by looking at the patient, you can know whether the patient is sick or not, right? And the next, very important in our country, is to also ask yourself whether the patient has got any infection that you can dangerous to you and to the other healthcare workers and other patients in the emergency. Very important in our country. So is the patient got an infection which is contagious? This is so important in the COVID time, if you remember. Then you ask, what is the chief complaints which brought the patient to the emergency? And then you will do the initial triage, and then you have to do the retriage. So these are the 4 steps by which you triage any patient. So the first step is the first look, as I said, critical look, and you have to do this rapid assessment very quickly, 3 to 5 seconds. So to do the ABCD also, it doesn't take that long, isn't it? You just ask the patient to talk. If the patient is able to talk normally, then their airway and breathing are okay. Then you look at the heart rate and capillary refill, and you could do the circulation. Conscious level you already checked, and exposure, if they have any problems, you can do that. So this quick assessment, sometimes you may not actually do it A, B, C, D, E, but just by a critical look, you can know whether this patient has to be immediately go to the recess area or he can wait and be triaged. Okay, so this is a triage to either to be triaged. So there are many patients that they have to quickly go past the triage into the resuscitation area, and that is what this first look helps us to do. And this is why you need to have slightly experienced nurses in the triage. Triage step 2 is ask yourself whether this patient has got any infections which can be contaminated. As you know, transmission of infection can happen by contact, droplet, and airborne, right? So do they have any of these diseases? So obviously, a trauma patient who's bleeding everywhere is very obvious. No, that is the contact precautions you have to take. But droplet and airborne may not be that obvious. So you need to ask yourself this question. So is there any respiratory illness, influenza-like illness, or febrile respiratory illness? These are the short forms, ILI, influenza-like illness and febrile respiratory illness, which means that there may be droplet or airborne infection. And do they have acute gastroenteritis, or which again is a contact precaution. So this is key symptoms and signs you have to quickly see, and you won't ask a detailed history, but in the first few minutes you should be able to decide. And I want to emphasize that you're not actually looking for infection and then putting standard precautions. Everybody is infected unless proved otherwise. So the standard precautions of wearing a mask, a gown, and if necessary, glove, gown, and if necessary, a mask. You need to do that all times. And any patient who is septic. So infection is also another reason why you look at, because people who have sepsis, patients who have sepsis will have critical symptoms requiring immediate attention. So that is the reason you have the second step as looking for infection. So the first step is critical look for life-threatening emergencies so that they can bypass the triage. The second is to screen for infection. The third step is asking the patient what brought them to the emergency department. So patient-driven and nurse-driven. Very important to differentiate this. I'm just illustrating with this example. A patient will come and tell you that I'm having leg swelling and pain for the last 4 days. But as a nurse, you will also notice that the patient is short of breath. He's breathless. There is tachypnea. Patient is not complaining about it. So the chief complaint has to be looked at in 2 ways. One, what brought the patient to the hospital? And having brought here, what is that you want to put it as a chief complaint? So obviously, the chief complaint is a red flag here, right? The leg swelling and pain is, of course, there. If you just look at it, then you'll probably triage the patient into 3 or 4, whereas shortness of breath will be probably 2. Okay, so very, very important to look at chief complaints from the patient-driven chief complaints and nurse-driven chief complaints. So that is triage step 3. And step 4 is, I'll have a little bit more examples of red flags before we go to 4. So chest pain, difficulty in breathing, altered mental status, confusion, all those, then severe abdominal pain. So it could be either a perforation or a bleeding inside. So you need to look at these red flags. And uncontrolled bleeding, of course, is another red flag. It is all. So having done that, you go to step 4 is then you use the standardized system, whether you're using Manchester, triage scale, Australasian, or whatever, whichever is being used in your hospital, emergency severity index, this is where you use it. So before step 4, you have these 3 things: critical look, screening for infection, and chief complaints. And ask all that and then get into the triage. So based on the standardized triage, you will do a triage assessment. Now, when you're doing the triage, ask these 3 important questions. So when you triage, does this patient require immediate reassessment? How quickly, and how long can I make the patient? It's very, very important, because after triage, you will make the patient wait. Many of them wait before the doctor can see. So it's very important to ask yourself after your triage, so do I need to reassess the patient? And if at all I have to reassess, how quickly? So if you think, no, I have to reassess the patient within 5-10 minutes, it's better you triage them into the emergency department and not to make them wait in the waiting area. If you think that they can wait for more than 20-30 minutes, then you can safely put them in the waiting area. This is one of the reasons why now we have instances of patients collapsing in the waiting room because you don't think of this. Okay, so when you're doing the initial triage itself, ask when is my next reassessment for this patient going to be? And if it is less than 15 minutes, you should not be making the patient wait in the waiting area. So after that, you will be re-triaging the patient. In general, this is the reassessment guide. So level 1, of course, will require continuous nursing care, continuous monitoring. Level 2, if you triage, you need to reassess them after 15 minutes. Level 3, every 30 minutes. Level 4, every 60 minutes. And level 5, every half an hour. I mean, we don't have in India that much of waiting area waiting time in the waiting area as in the West. People wait for 3 hours, 4 hours in the waiting area in the Western emergency departments. So that is why this thing is put up. But this is also useful for inside the emergency also for you to decide how often you have to reassess patient, and you can actually empower the nurses. Instead of asking the doctor every time when I should reassess, the nurses can be empowered to say, okay, it's level 2, no, the reassessment is every 15 minutes, level 3, 30 minutes, and so on. But very important is when you retriage, don't scratch off that initial triage and retriage. The original triage level remains. That is the level in which the patient came to the hospital. It could become worse or it could become better. That is the progress of the patient in the emergency department, not the triage level. Now, after this, I think coming to the last section of my talk is special considerations. Now, we saw about the various levels of triage, systems, and then specific how to go about triaging a patient in the emergency department. Now, these are special considerations you have to remember, keep in mind when you are triaging the patient. So what are these? Pediatric patients. So you have to use modified tools. You can, for example, each of these, Manchester triage or hospitalization, there are some modifications recommended. And the approaches are different because the physiology is different. The vital parameters are different. So the approaches should be different. Communication will be difficult, and you have to use age-appropriate communication tools. For infant, it will be different. For preschooler, it will be different. Adolescent will be different. Parental involvement will be there, and it can also be a problem because you also have to handle parental anxiety in addition to the patient's anxiety. So these are considerations in pediatric triage. Geriatric, the other end of the spectrum, complex presentations. They will not be presenting textbook. They will not be presenting in vague ways. There won't be any fever, but they'll be presenting in sepsis, for example. And you need extra time to communicate. Many times there is difficulty in communication. So more time will be required to communicate and do the triage, and also the risk of polypharmacy. There'll be, a lot of medications that you decide whether it is drug related or really they're having a problem is all this will be confusing. So these are considerations you have to keep in mind in the geriatric age group. Obstetric triage again has to be very quick because you have 2 lives at stake. So you need to monitor both maternal and fetal well-being if they come to the emergency department. And again, a pregnancy brings in so many physiological changes. So you should be aware of these changes. The signs will vary. For example, as a surgeon, the abdominal examination and evaluation becomes very difficult because of the uterus pushing all the organs out. So these things you need to be aware of. Trauma is a totally different ball game. So the principles in trauma is again the same. People patients who require immediate attention, and you need to prioritize them based on the likelihood of survival. I'll tell you these are 2 different things, maybe opposed, but where they have to be used. Because there are 2 ways in which the trauma patients will be triaged. One is the field of pre-hospital. So determine the most appropriate destination facility they should be transported. Do you go to the nearest primary care center or to the nearest trauma center which has got all the facilities? This is a decision that has to be taken by the paramedic in the trauma situation. Hospital-based is the same to assess the severity. Now, how do you decide whether you take them to the nearest hospital or to a tertiary hospital which has got all the facilities? So you use this flow chart. So first is to assess the vital signs. If the Glasgow Coma scale is less than 13, systolic blood pressure is less than 90, respiratory rate is less than 10 or greater than 29, that is one criteria. Okay, assessing the vital signs. Next is anatomy of the injury. All penetrating injuries, 2 or more proximal bone fractures, humerus or thigh, 2 or more, crushed pulseless extremity. That is the severity of or anatomy of the injury. The third is mechanism of the injury. Falls greater than 20 feet for children, more than 10 feet for adults. High risk auto crash, that is, speed is very high. And automobile, not auto rickshaw, okay? Automobile versus pedestrian and motorcycle crash who are going more than 40 kilometers per hour. So this is the mechanism of injury. And the fourth is special needs, older adults, children, people with burns, pregnancy. So if any of these criteria is positive, you need to go to a trauma center, right? Because they need complex treatment. If they are not there, then you can take them to the nearest hospital, even if it is not that well equipped. So this is how the pre-hospital personnel triage trauma patient to take them either to the nearest facility or to the highly advanced trauma tertiary care facility. In the hospital, again, there are two types of triage which has to be done in trauma. Is it a multiple or mass casualty? What do you mean by that? Multiple casualty is where you get a number of people into the emergency with trauma. Maybe, 3 or 4 people, had, there was a road traffic accident and the injuries do not exceed the capability of the facility. So here, what is your principle? Those with life-threatening injuries will be treated first. Okay, normal triage systems will be used. So there is multiple casualties. Whereas mass casualties is suppose train accident, okay, or rail accident. I'm sorry, rail accident or multiple crashes on the road. So there are 30, 40 people or industrial accident where you have 30, 40, 50 people coming to your hospital. So that is mass casualty, where the severity of the injuries exceed the capability and of the facility and staff. So here it is reversed. So those having the greatest chance of survival with the least expenditure of time and equipment are treated first. It is not fair, but that's how it works, because if you have a lot of patients to treat, those who have chances of survival should be given all your resources so that they survive. Don't waste your resources on somebody who's only got 2% chance of survival. Okay. So here very simple triage systems like color tags and star triage systems are used. Okay. So rapid assessment, resource allocation, ethical considerations, very, very important. You need to be transparent. You need to take decisions under pressure. So you have to be very careful in these sort of mass casualties and disasters. So here is a system, some systems which can be used, as I said, start, simple triage and rapid treatment based on their ability to walk, respiratory status, perfusion, and mental status. Then there is one called SALT, assist life-saving interventions, treatment and transport. So you combine the intervention and transportation. And Jumpstart is the same thing adapted to pediatric age group. So here is one example of how they will be triaged. So you do this also known as the sieve triage. If the patient is walking, becomes priority 3. No, it is delayed. So these are called minor injuries, minor disaster injuries. Not walking, lying down on the floor, is the patient breathing? No breathing, no movement, even after opening the airway, they are not alive. So that is black. They will be tagged as black and they go to the mortuary. If they are breathing and lying down on the floor, assess the respiratory rate. Less than 10, greater than 30, priority 1. If the respiratory rate is between 10 and 29, look at the capillary refill or heart rate. There is no time for assessing blood pressure and things like that. Okay. So if the capillary refill is greater than 2 or if the heart rate is greater than 120, again, they go into priority 1. If it is less than 2 seconds, less than 120, priority 2. So the rest of the patients who have extensive injuries will be decided by a senior person. Okay, they go into what is known as the expectant group. So quickly you will be triaging them into minors, mortuary, rhesus, majors, and prior expectant by doing this 4 things, which will only take you a minute or less than a minute. So that's how mass casualties are triaged. As I told you, ICU also needs to triage based on clinical severity, benefit of ICU care, and availability of resources. Okay, very important to do that. So it will be done first with the emergency physician and then refer to the intensivist, or there may be a committee also deciding whether the patient needs to go into the ICU. And you need to do ongoing assessments. So you'll use physiological parameters, scores like Apache and SOFA score, sometimes to decide on this, and or local guidelines based on evidence. Outpatient triage is also needs to be done, and this will be one, triaging them to the appropriate departments. Okay, they come to the reception and they have to be triaged to the appropriate departments based on the symptoms, severity. So I'll be sitting in the surgical clinic. There may be post-op patients who are in pain. There may be a patient who's come with abdominal pain. There may be another who is sort of fractured the finger, and there may be someone who just came, for a review after 30 days. So do I put them according to time slots and see them, or do I triage them? Most of the hospitals, still have not started following this triaging in the outpatients, but NABH has started asking that, and so we have to get ready for that. Telephone triage systems also exist, where there are clear indicators. By telephone, you can triage them into various hospitals or facilities, by using standardized tools or computer decision support systems. Finally, in the era of AI and telemedicine, we have to talk about teletriage and remote triage. So what is the difference? Teletriage is triaging them remotely using like this Zoom or video conferencing and online symptom checkers. Whereas remote triage is where there's no direct patient interaction through somebody else, but using digital tools, artificial intelligence, you will be triaging them remotely. Okay, this is slowly coming into view, and especially in remote areas where there is not even a doctor available, or even there is no wireless or internet connectivity. So that's teletriage and remote triage. So friends, so that's my short rant on triage. To summarize, philosophy and principles of triage is very important. It is maximizing efficient use of medical resources to benefit as many patients as possible. And types of triage is in field and disaster triage, in-hospital triage, triaging in special population, teletriage, and remote triage. There are various triage systems available. You pick whatever you want to, according to your hospital policy. Manchester, Australasian, Canadian, emergency severe, which is American, or modified early warning scope, or devise your own and call, make in India. Triaging skills are very important, as I told you, and I briefly mentioned of the 5 steps of triaging. Okay, critical look, screening for infection, and then looking at the chief complaint of the patient, both from the patient point of view, from the nurse's point of view, then using any of the systems to triage, and then retriaging them. There are, of course, ethical and legal consideration. Many patients do not understand why I am being made to wait, though I came earlier to the emergency department. So a lot of angry patients and aggressive patients also you have to handle, because if you don't explain them very clearly the triage process. And triage has got its own challenges, and innovations, as I said, are coming slowly with the introduction of AI. So with that, I'll end this talk on triage. Thank you so much for your patient listening, and again, we'll meet you next week. Thanks again.